A very good morning to Dr. Huei, Consultant General Surgeon, Dr. Harn, Consultant Gastroenterologist. Ladies and gentlemen, thank you for joining us for StarLIVE Detecting and Treating Colon Cancer. I am Denise and I will be your host for today. Ladies and gentlemen, before we begin, allow me to share with you what StarLIVE is all about. As a way of connecting with you, our readers, Star Media Group presents an exciting array of talk sessions covering various topical matters of interest, from guides to leading a healthier lifestyle to meet and greet sessions with personalities. Our guest speakers for today's StarLIVE session are Dr. Huei and Dr. Harn from Subang Jaya Medical Centre. Colon or colorectal cancer is preventable and curable if detected in early stages. Today, our guest speakers will be sharing with us everything you need to know about colon cancer, from detection to the latest treatments available for patients. Ladies and gentlemen, at the end of the session, there will be a Q&A opportunity with our guest speakers. Before we begin with the talk, just a few housekeeping rules. Please switch your phones to silent mode, and please reserve any questions that you may have for the Q&A session. And now, without further ado, let's welcome Dr. Harn to the stage to shed light on early detection and the importance of recognizing the symptoms of colon cancer. Dr. Chen.
Very good morning, ladies and gentlemen. Thank you, Denise, the chairperson for the event today. Thank you to Star for inviting me to this event to talk about colon cancer, a very important topic that I would like to share, and it's something personal to me too. And thank you, ladies and gentlemen, for taking time off this morning to come and listen to me present on colon cancer. So the topic of my presentation today is colon cancer, how screening prevents cancer and also saves lives. So this is a picture in the colon through endoscopy, and that's a colon cancer. So this is something that both gastroenterologists and surgeons hope not to see, because we want to try and pick it up before it becomes a cancer and basically prevent this from happening. This is where I work in SGMC. So just a quick overview of the presentation today. I would be talking about colon cancer. How common is it? How does colon cancer arise? What are the symptoms when you have colon cancer? What are the risk factors and the prevention of colon cancer? What can we do? And the screening methods for colon cancer. And also just briefly on what happens once a patient is diagnosed with colon cancer. So this is the World Health Organization data on newly diagnosed cancer in 2018. So if you look at the screen, there were 18.1 million cases worldwide of newly diagnosed cancers. Again, these are only cases that has been registered, so the number is probably much, much more than this. And if you look at the Asia, we have the highest number of population, so the highest number of cancers as well. So 18.1 million. So out of this 18.1 million, colon cancer is actually the third most common newly diagnosed cancer. It accounts for about 10% of all the newly diagnosed cancer, which is about 1.8 million cases. What about Malaysia? In Malaysia, we do have a cancer registry as well. And the data that we have so far is from 2007 to 2011. The latest data is still pending. And from that data, we know that colorectal cancer is the number 2 most common cancer in Malaysia. So it's very common in Malaysia as well. Okay, so in Malaysia, the first most common cancer is still breast cancer. Yeah, so 17.7%. Colorectal cancer is number 2 at 13%. Colorectal cancer accounts for about 16% of cancers in men. So in men, it's the most common cancer, whereas for women, it's the number 2 at 10%. So it's a very common cancer. And if you look at the age distribution of patients with cancer, for colon cancer itself, predominantly is above 50. Yeah? So as your age goes up, if you don't go for any screening, you find that the incidence of cancer increases. But if you look at the world data on colon cancer, there are countries which have organized screening for the population. So it's a government-based initiative where they actually offer screening to the population. And in those countries like the States, Australia, we know that colon cancer in those above 50 has dropped significantly because of the screening. But the cancer in those below 50 has actually increased almost 2 to 4 times. So it's getting younger. If you look at the lifetime risk in men, if you look at the lifetime risk in men, 1 in 56 chance of having a colon cancer. Highest in Chinese, 1 in every 39 for men, 1 in 49 for women, Chinese women, followed by the Malays, 1 in 72 for men, 1 in 100 in the ladies, and for Indians, about 1 in 82 for Indian men, 1 in 91 for Indian ladies. So it's quite a common cancer. So how does colon cancer arise? Colon cancer, majority of it arises from a benign growth called polyp in the colon. Majority, about 80% of it would be what we call an adenomatous polyp. And this polyp basically follows a sequence where you have the polyp, which is benign, it's called adenoma. It forms dysplasia, which is basically changes within the polyp. It's a mutation, and then it becomes a cancer. And it takes about 10 to 15 years before the polyp becomes a cancer. There are other polyps which can cause cancer as well in the colon, such as serrated adenomas, hamartomas polyps, but these are slightly less common. So majority of the polyps that we see and we treat would be the adenomatous type. So these are pictures of how a polyp looks in the colon. You have the sessile type. You have the pedunculated where they have the stalk, and this is when it becomes a cancer. So what are the symptoms of colon cancer? So before we go into the symptoms, I think the first thing I would like to emphasize is that by the time you have symptoms for colon cancer, the cancer is already an advanced cancer, probably stage 3 to stage 4, because early cancers do not have any symptoms. What are the symptoms that patients present? The most common would be a change in bowel habit. So you can get constipation, diarrhea, or alternating constipation and diarrhea. These are actually very, very common symptoms, but the symptoms should be prolonged, and this happens in about 40% of patients. Passing blood in stools in 35% of patients. So the blood in stools can be from fresh blood, red blood, to what we call hematochezia, which is maroon-colored altered blood, or even the melena, which is the black-colored blood. So it depends on where the bleeding is arising from. Quite a number of patients actually present with abdominal pain as well, weight loss, anemia, which is a low hemoglobin from bleeding, and sometimes they do also present with obstruction of the intestine. So again, all these symptoms are late. By the time you have these symptoms, the cancer probably would have been quite advanced. So what are the risk factors for colon cancer? The strongest risk factor would be a family history. If you have one family member, first-degree relative with colon cancer, your risk goes up by almost 2 times. If you have 2, it goes up to about 3 times above normal. And you also have all these hereditary colon cancers. It's a genetic condition such as HNPCC, familial adenomatous polyposis. trigger where they get colon cancer at a very, very young age. So if you have a friend or family member who has colon cancer at a very, very young age, they have to be screened for all these genetic conditions as well. Yeah. Patients who have inflammatory bowel disease, which is a condition where they have inflammation of the bowel, prolonged period of time, they do have an increased risk of colon cancer as well. And there are also some lifestyle risks which we know that is associated with a higher risk of colon cancer. So if you look at all the colon cancers, majority of it is sporadic, so no family history. There are some who have familial, about 10 to 30%, whereas the genetic condition is actually very rare, less than 10%. So what are the lifestyle risk factors that increases the risk of colon cancer? We know that smoking increases the risk of colon cancer. Patients who are obese, those who have a high intake of red meat, patients with diabetes, patient who consumes a large amount of alcohol. So all these are lifestyle risk factors, but if you look at the observational data, the risk from family history is still the highest. Yeah? But these are things that you can try and adjust to prevent colon cancer, to reduce the risk. So how do we prevent colon cancer? Adjust the risk factors that you can change. So reduce smoking, stop smoking, reduce your alcohol intake, be fitter, prevent diabetes. But the most important method for prevention is screening, which I would like to emphasize afterwards. Yeah. So screening for colon cancer saves lives. What we want to do is we want to try and pick up the lesion when it's a polyp before it's a cancer. If you treat it, basically you're preventing cancer from happening. So among all the cancers, colon cancer is probably one of the most preventable. There are quite a number of screening methods. We have stool tests, we have imaging, we have endoscopy, which is the dreaded colonoscopy. There are also some blood tests which are available recently, and I'll go through them with you. Yeah. The important thing I would like to emphasize is that when we have a lot of people going for blood screening in the labs, and one of the screening tests that they always say is that you have the CA marker, which is a colon cancer marker. I would like to stress that it's not an accurate test. So we have a lot of patients who have colon cancer with a normal CA level. So having a normal level doesn't mean that you don't have colon cancer. And having a raised CA result doesn't mean that you have as well, because it's not a very accurate test results. Okay, so going to the screening test, the most common is actually stool test. So in countries which have a screening program, because of the cost of endoscopy, which is very high, the country screens the population by doing stool tests first. And the common stool test that we do is stool test to check for blood. The old method is the Huei, which we don't use anymore. And the ones that we use now is the fecal immunochemical test, which has antibodies which detect blood. So how the patients do it is that they get a kit set. There's a cart there with a device, a spatula to scrape part of the stools. And what you do is as you pass motion, you take the stool, you smear it on the cart, and then you send it to the lab. And there they will give you a test whether the blood is positive in your stools. If you use this test, if the test is positive, you will still have to go for a colonoscopy to see where the source of bleeding is from. If patients prefer to opt for this screening method first, basically you have to do this stool test yearly for it to be effective. So every year you have to do it once, and if any time along the way it becomes positive for blood, then you go for the colonoscopy examination. So the FIT test, which checks for stool blood, is sensitive. It's quite a fairly good test. 70% of colon cancers will be detected from the stool test. We do have new stool test as well, which combines the FIT with the fecal DNA for colon cancer. The sensitivity is much higher, about 90%. I think they're doing it in trials now. but it's very expensive. There's also another stool test that we call the M2PK, which I think in Malaysia, some centers do offer that, which offers about a sensitivity of 80% to pick up colon cancer. So it doesn't mean anything much. If the test is positive, you have to go to the next step of doing the endoscopy to find where the source of bleeding is from and whether there's a cancer in the gut, in the bowel, sorry. What about imaging? So all these are non-invasive, because when you talk about endoscopy, it is an invasive procedure. You have to put a device in to check your gut and colon. So some people prefer not to do that. So they prefer to do non-invasive tests, so stool tests. What we can do is imaging as well. Previously, patients used to do what we call a barium test, where they inject some dye and they take x-rays. So that test is not accurate. We don't do that anymore for colon cancer screening. So for patients who are not very fit for procedures, or patients who don't want to do endoscopy first, they can do what we call a CT colonography. There's also capsule colonoscopy, which is also starting to pick up in the States, where they swallow a capsule with a video camera to go down into your colon and look at the presence of polyps and cancer. So the downside to this is that you still need bowel preparation. So one of the problems with endoscopy is that you have to drink quite a large amount of liquid to clean your bowel. But if you opt for this test like CT scan or even the capsule, you still have to go through the bowel preparation before they do it. The CT scan screening is not as good for very small polyps, for flat polyps. It's more accurate for polyps which are bigger than 1 cm. But these are the polyps that have a higher risk of changing to cancer or already become a cancer. Yeah? The downside to this as well is that it's expensive and you still have radiation exposure, X-ray exposure from this. And if you do CT colonoscopy, the recommendation is once every 5 years. So you do it, if it's negative, the next 5 years, you have to do it again. And if you do find polyps in the scan, you still have to go for endoscopy to treat and remove the polyps. So endoscopy is probably the most common method we use for screening. Other than screening, it also helps to basically treat at the same time. So if you remember the previous tests that I mentioned, the stool test, the CT scans, if any of those tests are positive, you will still have to go through this procedure. And how we do it is, after taking the bowel preparation, where you clean your colon, you would come into the endoscopy suite where we would introduce a device, which is a long tube with a high definition video camera into the colon. Yeah? And from there, we get very good views of the whole of the colon all the way to the end of it. We try and find whether there's any polyps, whether there's any source of bleeding, whether there's any cancer. And at the same time, if we find the lesion, we can actually treat it, most of it endoscopically. So for endoscopy, we have two types, either the flexible sigmoidoscopy, which basically looks only at the left side of the colon. Sometimes we do that for younger patients who present with bleeding, because if you have fresh bleeding, usually the bleeding is from the left side of the colon, but you don't examine the full colon itself. It can be done without the bowel prep. Basically, we just give an enema, get them to open their bowels twice, and then we do the flexible sigmoidoscopy. So if you look at the image before, so flexible sigmoidoscopy would examine all the way somewhere to this area, yeah, near the descending colon. And you can do it without sedation for this procedure. But if you find polyps in the left side of your colon, we will remove it straight away, but you will have to do a full colonoscopy to look at the right side as well. Whereas for colonoscopy, we examine the full length of the colon all the way, sometimes even into the small intestine at the end of it. It's both diagnostic. We find polyps, and then we will treat it straight away. And basically, by treating the polyps, by removing the polyps, you're actually preventing it from becoming a cancer. If we do find a lesion which looks like a cancer, then most of the time we will not remove it. We will just take biopsies to confirm the cancer presence, and then they have to go for further treatment by staging and then surgery after that. So the disadvantage to doing colonoscopy, one, it requires bowel prep. I think that's the thing that most people fear, drinking that large amount of water, going to the toilet many times to clean your bowel before we do the procedure. The other concern is that pain or discomfort from the procedure. So I would like to reassure you all that this procedure by and large is very comfortable. So what we do is before the procedure we will give sedation. It's a medication to make the patients sleepy and comfortable. So most patients, what they experience is going to the room, being given the medication, falling asleep, and then waking up when everything is done. So they don't actually feel pain or discomfort. Of course, we do have patients who are very, very anxious. They come to the doctor and say, I don't want to be awake at all. I will get a panic attack if I wake up halfway through the procedure. So for those patients, we can get the anesthesia doctor to be there, and they will give stronger sedation. So those patients are 100% you'll be sleeping throughout the whole procedure. You won't wake up at all until the procedure ends. By and large, endoscopy is very safe. If it's not safe, those countries wouldn't institute the screening program for colon cancer screening. So there are some small risks involved with the procedure. Firstly, bleeding. When we remove polyps, which is less than 1%, most of the time, even if it bleeds when we take out the polyp, we can stop it through the scope. The second thing is, of course, the risk of perforation, which is basically a hole occurring through the colon from the scope itself or when we remove polyps. But that risk is very, very rare. It's about 1 in every 5 to 10,000 risk, so 0.01% roughly. And of course, there are some small risks with sedation, but generally the patients will be monitored throughout the whole procedure. So by and large, a very, very safe procedure. So how much does it actually reduce colon cancer? So in countries that has instituted a screening program, when we look at the colon cancer death risk, we know that it reduces colon cancer death by up to 80%. So that's why I mentioned earlier, those above 50 in those countries with screening program, the colon cancer death risk, colon cancer rate, all has dropped very significantly. Somehow the protection from colonoscopy for the right-sided colon lesions, which usually are flatter, is not as good, but it still reduces it quite significantly by about 40 to 60%. For the sigmoidoscopy, from studies, it reduces the risk of colon cancer death by about 26 to 70%, depending on different studies, but all this is only for the left-sided colon cancer. Okay, I'm just going to show you a small video of how we actually do the colonoscopy and how we remove the polyps. So that's a polyp. Yeah, it's quite a large polyp. It's about 1.5 cm. So nowadays we can remove very, very big polyps now. Yeah, so because it's a big polyp, what we do is we inject the base of the polyp to give it a big cushion so that it's a bit safer to remove. So this liquid has a bit of dye there, which makes it make the polyp show up a bit clearer. So we know we can see it much clearer when we inject the dye and give the cushion as well. So previously, large polyps has been referred to surgeons to remove surgically, but with the improvement in technology and also the technical skills, we can remove by and large almost all the polyps. So the only things that we don't remove is when it's become a cancer, apparent cancer, because those need surgery. So this is how a flat polyp looks like in the colon. And what I'm doing now basically is I'm trying to get the snare, which is the device to cut the polyp out. So there's a bit of delay while we are trying to introduce the device into the instrument channel. This polyp, if you leave it, within a few years, it would be a cancer already. So that's why when we do this colonoscopy examination, we cut it out. Then basically you're preventing it from becoming a cancer. So that's a snare device. It's actually a metal wire that we will put across the polyp. And then with this device, we can apply an electric current to actually cut off the polyp. So it's easier to explain looking at this rather than mentioning it. Yeah. So we close the snare. It's a bit big, so I have to actually release the snare a bit and take a smaller portion. So we are doing what we call a piecemeal resection. So just releasing a bit of it because there was a bit too much. And then we apply the current. So you can see it burning now. And the polyp is taken off. So there's still a small nub there which we will remove in the next few seconds. It looks scary, but it's actually very safe. Okay, so if you look at the polyp removal side, it actually heals very fast. If you go back within, let's say, a few weeks, a week, 2 weeks, most of the time that area will just be a small scar. So the colon heals very well. So it's not something that causes permanent damage to the colon. And by doing this procedure and removing the polyps, basically you're preventing it from becoming a cancer. What about blood tests? Recently, I think in the States, there's a new blood test called Septin-9. It's the first FDA-approved blood test for colon cancer. Basically, it picks up these changes within the blood, which is arising from colon cancer, but it's actually got a very poor sensitivity, just about 50%. It's very expensive, but they do this because there are patients who are worried about doing other screening procedures like scope, so they want to do a simple thing like blood tests. So it's available, not in Malaysia, but in the States. They may find some new blood tests in the future which may be a bit more accurate as well. Again, I would like to emphasize that the tumor marker CA is not a reliable marker, so please don't use that as a screening test for colon cancer. So as I mentioned earlier, if you adhere to the screening program, it can reduce the risk of colon cancer by up to 80%. So for patients on average risk, that means no risk factor, we normally recommend starting screening at the age of 50. In the States, they are actually trying to bring it down to 45 because, as I mentioned before, the colon cancer rate in those below 50 actually has quadrupled. So they are trying to bring it down to 45. And even personally, from my patients as well, there are quite a number of patients who actually present quite young, although it's still rare. Yeah? So in their 30s, in their early 40s. So for those with family history of colon cancer, you start the screening at the age of 40 or 10 years earlier than the youngest family member. So if you have a family member who has colon cancer at, let's say, 45, then the family members all should start by the age of 35. So 10 years. Why the magic number 10 years? Because that's how long it takes for the polyp to become a cancer. So when we do the screening, we are trying to find it as a polyp rather than a cancer and remove it. And thereby we actually prevent the colon cancer from occurring. For those who are high risk, for example, those who have genetic family history, like FAP or Lynch, the screening actually starts much earlier, and you actually do it more regularly compared to those with average risk. So if you're on the colonoscopy screening program, when do you do the next scope? If you have no polyps at all during the endoscopy, basically you're protected for about 10 years. So we say 5 to 10 years, depending on whether your bowel preparation is clean. So if the colon is very clean during procedure, then 5 to 10 years you don't need to repeat the procedure. It protects you for that long. If you have a polyp, 5 years. If you have multiple polyps, 3 years. If you have polyp with high-grade changes, then within a year you should have a screening again. And then your subsequent endoscopy screening after that will depend on the latest colonoscopy finding. Yeah. Okay, so bad news. If you do have colon cancer, yeah, what happens? When we do the endoscopy and we find colon cancer, we will take small biopsies to confirm in the lab that it is a cancer. And then what we need to do is basically stage the colon cancer. So with this, we do things like CT scans, MRI of the rectum, the lower end for rectal cancers. Some patients, we might have to do a PET scan, which is a glucose with a radiation to see whether there's any distal spread, or even a procedure called endo-ultrasound to determine the depth of the cancer. So the treatment actually depends on the stage of colon cancer. If it's an early stage, stage 1, stage 2, surgery is basically a cure. Yeah? For patients who have more advanced cancer, they might need chemoradiation, and some might need it even before surgery. Yeah? And even for those who have already stage 4 or cancer that has spread, the chemotherapy itself can also slow down the growth of the cancer. Yeah? And we do have a lot of new therapies which are coming up, things like immunotherapy, molecular targeted therapy, which actually shows very, very promising results. So having colon cancer, bad news, but it is one of the most treatable cancers. So if you have early cancer, stage 1, yeah, stage 1 cancer, your survival, 5-year survival is about 90-something%. And just by doing surgery, it's basically a cure. If you have stage 2 cancer, where the cancer is a bit bigger, the survival is still quite good, about 70 to 80-something%. Stage 3, when the cancer has gone to the nodes, it's still quite okay for 5 years, 44 to 60%. And if it's stage 4, that's the poorest prognosis, about less than 8% in 5 years. But again, with the advent of the new target therapy, new chemotherapy drugs, actually the survival is actually increasing. Yes. So in summary, colon cancer is a very, very common cancer. It arises from lesions that we call polyps, and it takes about 10 years, 15 years before it becomes a cancer. The family history of colon cancer would increase one's risk of it significantly, and it is actually very preventable, yeah, if you do the screening. So again, screening starts at 50. If you have family history of a younger colon cancer, then 10 years before that, or at the age of 40. Thank you.
Thank you, Dr. Chen, for the insightful presentation. For the next session, may I please invite Dr. Huei up on stage to talk to us about a minimally invasive approach for patients.
Good morning, ladies and gentlemen. Thank you for coming. And to thank the staff for organizing this event and bring us together to share about colon cancer. And Dr. Chen has told us about how, when to screen, why we need the screening. And actually, I basically tell my patient, you should start your screening at 40. This is what I tell my brother. So today what we're going to talk about is what is gastrointestinal tract and colon in particular, and why surgery is needed for diseases of the GI tract, and what is the difference between the open and minimally invasive surgery such as laparoscopic or robotic surgery, what preparation is needed from the patient perspective, and also what should you expect after the surgery, the complications from the surgery, as well as what other GI surgery that can be done through minimally invasive procedure. So, what is a gastrointestinal tract? Basically, it's a hollow tube starting from your mouth all the way to the anus. And basically, when the food comes through the mouth, go to the food pipe, the esophagus, go into stomach. The first part of the small bowel is the duodenum, and then go to your small intestine. And colon is a large intestine. The last part of the colon is the rectum, which is about, I'll tell you later more about this. And there are other accessory glands, such as your salivary glands in your mouth. The liver is the other accessory organs that process digestive system, and also gallbladder and pancreas. So how about the colon? So colon is a large bowel, or we call it large intestine, and it's a muscular tube, and it's about 5 feet long, and it's part of the digestive system that absorbs water and salt from the food, and it stores water matters. The rectum is the last 15 centimeters of the digestive system. And why we need surgery? Luckily for most of us, most of the gastrointestinal disease do not need surgery. But there are many others that may require surgery, such as your cancer of the esophagus, maybe anti-reflux surgery to prevent those who have very bad reflux problem, and cancer of the stomach, or even now is more popular is the surgery for obesity. And we also have gallbladder problem, small intestine tumor, large intestine tumor, even your hemorrhoid. So how about in colon in particular? Just now Dr. Chen already told us, if the polyp has become cancer, the only choice most of the time is to do surgery. So the first reason is the most direct way to remove the tumor. If the tumor is T1, we call it very superficial tumor, you may be able to get away by doing what we call removal through the scope, like Dr. Chen described, because the tumor have not gone to the muscle layer. But in general, most of the tumor that we detected are already quite late, okay? So that's why we need an open surgery. See, the third this picture here, the last one, yes, this is become a cancer. So you probably need a surgery to remove it rather than a scope for this middle one. And you can either, such as this tumor, you can't actually remove it through a scope because it has gone through the muscle layer. And if you just remove through a scope, you will leave the tumor behind. So we can do a traditionally open surgery, or a keyhole surgery, or laparoscopic surgery, and this is the latest robotic surgery. So second reason why we want to remove the tumor. Not only we want to remove the tumor, we also want to know how the tumor behaves after the surgery. Because by staging the tumor, we will know how long it's going to live after the surgery. Because if, like Dr. Chen earlier told you, if you are stage 3 disease, the tumor has already gone to the lymph node. So it will significantly affect your survival after surgery. And it will allow us to decide, is there additional treatment needed for you, chemotherapy or other immunotherapy? So the third reason is for very obvious reason. Some patients present very late. They present with a bowel obstruction. The intestine is all enlarged in this X-ray because there's something's blocked down there. Or present with continuous bleeding. The patient have anemia, can't even function well after for the activity of daily living. Or this is a near obstructing tumor. Well, it's not blocked yet, but patient have a lot of symptoms, a lot of bloating, a lot of pain, discomfort. So there's an obvious reason why we need the surgery to remove it. So what is minimally invasive laparoscopic surgery? Basically, it's similar to open surgery. We do exactly the same thing. We train through the open surgery and evolve into laparoscopic because we just do the surgery through a multiple small hole, okay? And the main purpose so that patient have a much better experience with the surgery, have less pain, and can leave the hospital earlier. So what other surgery can be done through laparoscopically? Not only colon, there are actually pretty much everything nowadays we can do through a keyhole surgery. You name it. You can do it through esophagus, do an anti-reflux surgery through laparoscopic stomach surgery, liver, gallbladder, which is very common, and also pancreas, colorectal. We also do laparoscopic surgery for emergency cases like appendix, perforated intestine, bowel obstruction sometimes. And of course, this is the main thing, laparoscopic surgery for obesity, because traditionally, if operating on a very big patient, you need a very big cut. And the problem that we face at the old time is we have a lot of complication from surgery for operating on a very large patient. The wound tends to doesn't want to heal well and cause a lot of infection. And the patient also, because of pain, doesn't want to breathe. So we have a lot of problem with operation on obese patients. But because of laparoscopic surgery, you have improved the patient outcome significantly until it's so popular nowadays that we can pretty much nobody do obesity surgery with open surgery anymore. For colon, as I tell you, we do exactly like open surgery. There's a tumor on the right side near the small intestine. We do a laparoscopic right hemicolectomy. The tumor near the corner, a hepatic fracture, we do extended right. If the middle of the colon, transverse colon, we just remove this part and the left side, and subsequently the other colon, if the tumor is near the rectum, lower part, we do what we call anterior resection. I'm not going to show you pictures or videos because sometimes it's a bit bloody. And most patients ask, do I need a bag when they come to do surgery? Do I need a bag? My friends have a bag. So actually, it all very depends on the tumor itself. It's very rare a patient come to see us require a permanent colostomy bag. It's very rare nowadays. Because those tumors, unless it is involved in the anus, because there's no way for the doctors to connect it back, to give you back a continuous ability to control, okay, by saving your sphincter muscle at the end, if the tumor have involved the anus. So in that case, probably the doctor will tell you, yes, you need a permanent colostomy. But most of the time, it depends on the condition of the patient. Some patients come in with obstructed tumor, cannot pass stool already. And if you join, we as a surgeon cannot clean the intestine well. So what we do in that case, we'll tell the patient, you may temporarily need a bag. We temporarily divide the tumor, bring out the tumor, cut into half, and bring the colostomy bag out through the abdominal wall. And this, most of the time, is temporary. It can be joined back. Okay? This is for emergency cases. Some condition of patient is quite sick when they come to see us. They are very malnourished. They have very low hemoglobin. So it all affects your healing process. So we also will be hesitant to join the two intestine back. Some patients develop complications after surgery. And we told the patient we join it back, and then it failed because there's a leakage. So we have to tell the patient we have to go back into the hospital, to the operating theater, and to do a colostomy bag for him temporarily. So the advantage of doing the surgery keyhole, that means using a laparoscopic, is you actually have less pain, definitely have less pain. You will stay shorter in the hospital. I find it slightly different context in Asian society when I come back. Because probably in the West, in the United States, the insurance keep pushing patients out of the hospital. Okay, patient come in, they just 3 or 4 days try to push them out because the insurance is paying for it. Okay, but in Asian, my practice, most patients say, no, I just want to get well. I can stay as long as you want. No, so I think things affect much to you when certain patient can, don't worry, I can stay whenever I'm. So, and it does help you to eat more, solid food faster if you do a laparoscopic surgery. And also have a bowel motion earlier, and you're able to go back to normal activity, and of course, cosmetic outcome. So, but is it safe to do keyhole surgery? I told you we do exactly like open surgery, but is it then, because most patients will tell me, no, I want you to do open because I want you to see everything, touch everything, remove everything. So I say, yes, yes, actually, but if you do, studies have shown, if you do keyhole surgery, your result will be as good as open surgery, because multiple studies have been shown, it's many, many years ago. The overall survival compared laparoscopy and open is the same. Your disease-free survival, that means you live until you have recurrence. It's also the same. If you have a recurrence, that means cancer come back. Also the same. So pretty much it's safe to do laparoscopic and open. In general, if you compare open and laparoscopic surgery, what we say is why open is good, because we can feel it, we can touch it, we have a range of degree of freedom, we can go in, come out, left, right, we can rotate our hand, we can have 3D image, and it's faster, hand-eye coordination easier for the doctors. Of course, it's less sterile because your wound is bigger, it's more traumatic, it's more painful, tremor amplified, inpatient stay is longer. Laparoscopic, already shown, is well developed. We have been doing laparoscopic surgery since 1960s. Okay, but it's more since 1990s it's become more established, and it's less traumatic. We can see as well as open. Procedure time is slightly longer, but you do stay in the hospital shorter. You have a shorter recovery time. You are happier, and of course, learning curve. You need a surgeon that will know how to do it. And the freedom of movement is a bit restricted because we can turn left, turn right, go in, go right, go back, but we can't pronate our hand. That means pronation, supination. That means we cannot turn like this. Okay? It's the 2D images, and your surgeon's tremor doesn't mean they are bad. It's just that they probably drink too much coffee. But it can amplify because your assistant nurse will see why your hand is shaking today, doctor. Touch is decreased. Okay, the latest thing is robotics. Okay, robotics give you the same as good as like open surgery because you have a degree of movement, about 7 degree of movement. You will remove your tremor because the robot hold the instrument. You control the robot. It can do a small connection. It can basically show you how you can see it very well. You can do the surgery in Shanghai, the patient in KL, and you can sit down. It's give you a 3D images. It's also quite sterile, that means clean. But you cannot feel it. The problem is the cost. A robot costs maybe 12 to 15 millions to buy the machine, to maintain it, so the hospital have to charge you. The insurance still have not agreed to pay most of the procedure. That is a problem. And procedure time, I'm not a trained robotic surgeon. I'm never trained in it, so I would not recommend it if you come and see me. But it's still very in the infancy in Malaysia. I cannot tell you who is the best in Malaysia to do robots. None. Okay? But I can tell you who is the best to do laparoscopic surgery. So, are you a candidate for laparoscopic resection? Well, it pretty much depends on who you talk to. A surgeon will have your best interest in mind. He will not, if he cannot do, he will not tell you he can do. Okay? Because for you, most of the time, if a patient have a tumor, all he wants is to get it removed. So, we will give you the risk and everything that is involved, whether you do open and laparoscopic. And the choice is up to the patient. And also depends on the tumor of the condition, the tumor, the condition of your patient. So are there any things that prevent you from having a laparoscopic surgery? Yes. If you have very bad heart or bad lung, because to do laparoscopic surgery, we need to pump in the gas to the abdomen to inflate the abdomen with carbon dioxide. That will increase the pressure in your abdomen. So the blood return to your heart is less. So if you have weak heart, you will have problem to withstand the surgery. And you have a bad lung also. You have a bleeding disorder, so we will not encourage it as well. And you are very, very obese. Okay, sometimes what means very, very obese is your BMI is approaching 40. Because to do the instrumentations are a bit difficult to manipulate through a thick wall. And you have a perforated tumor. Tumor is very large. You are sepsis, that means you presented with bowel obstruction. You have already the tumor almost perforated. And you have previous surgery because it caused a lot of scarring in the abdomen, so we will not recommend it as well. And some just like pregnancy, we have not much space even when your bowel is distended. So we may tell you, yeah, your condition probably not suitable for laparoscopic surgery. So how do we do it? So we gain access to abdomen. In open surgery, you cut open in the middle. For laparoscopic surgery, we make a small hole. And then we'll introduce this thing called trocar, a cannula, go through the abdominal wall. It's about 10 mm or 5 mm. And we have a laparoscope, a camera called laparoscope connected to a video camera system that we can see in a 2D image or 3D. And several cannulas are inserted to create a multiple hole so that we can do. We may have to enlarge one of the cut to make it bigger to remove the tumor. Okay, so the tumor, this trocar, the biggest one is 12 mm, but the tumor, let's say your tumor is 4 centimeters. So we have to cut the incision slightly bigger to remove the tumor at the end of the procedure. So what happens if we cannot do the procedure? Like I said earlier, patient is very obese, have a history of previous surgery, and we cannot see it well. If we look at it, we cannot see well. It's very blurred, or if a lot of bleeding, we cannot control. So we may have to open the patient up to complete the procedure. Okay, conversion to open surgery is not a complication because we will tell you earlier, it's for your best interest. So what preparation are needed for patients who are diagnosed with? Once you're diagnosed with a colon cancer, you probably need a CT scan or PET-CT to look at any area that's in other areas involved, whether the tumor has spread to other area. And so important thing is the blood work to look at how, in general, how well are you, the kidney function, your hemoglobin level. We will see whether you need a medical evaluation by your cardiologist if you have heart problem before surgery. And we probably routinely do a chest X-ray and ECG. And of course, you will talk to a surgeon to get a written consent to tell you you may die from the surgery or you may not die from the surgery. And blood transfusion may be needed. This one is very rare nowadays you need a blood transfusion, but we will still do a tap and cross match. Shower before night or morning of the surgery. We will have to empty your colon again just like you would prepare for colonoscopy, okay? Because we don't like to see feces during the procedure. So we want you to at least have it clean. Unless your bowel is obstructed, we cannot do anything. We will give, some surgeon will give you antibiotic by mouth before the surgery. If you cannot complete the bowel preparation, you should tell your surgeon. And no food or drink except medication and sips of water in the morning of surgery. Well, you should stop your aspirin or some blood thinning medicine like Plavix. There are a lot more newer blood thinning medicine. You should stop at least 1 week, okay, because it will cause. And also you should stop your ginseng and garlic, vitamin E too. All these can affect the blood thinning. It can cause a lot of bleeding during the surgery, which is quite common in our population. And quit smoking. And one word about nutritional status. Almost 2 out of 3 of patients that come to see us for gastrointestinal surgery actually is malnourished. We don't know. Most of the older age group, they don't eat that much already. And their albumin level probably is lower. The studies should show if your albumin level is low or you are anemic, your complication from the surgery is higher. That means the wound doesn't want to heal as well as if you are well nourished. So it is very important to screen the patient. There is no formal screening in our hospital, I have to say. Even the insurance company will not pay for dietitian sometimes. So what we do, we will look at you, we will tell you your albumin level is low, you probably should take some supplement before surgery, okay? Here, the supplement is not your vitamin supplement. Here, the supplement is food, is the nutritional, real protein intake, carbohydrate, and fat. Okay, we will give you some milk powder to supplement your health before the surgery. It is very important. Because especially in this society, your neighbor, your relative will tell you, don't eat meat. Once you diagnose with cancer, don't eat meat, don't eat that, don't eat that. So, in fact, meat is more important at this stage. because you need all the protein you have. You need all the protein you can get to get through the surgery and maybe chemotherapy later. So that is very important. So what do you expect after surgery? Well, you should follow your doctor's instructions. We encourage you get out of bed early after surgery, okay? Because it will reduce the soreness of the muscle. You can move earlier. In fact, your bowel function will return faster after surgery if you move early. And you should back to normal activity in 1 to 2 weeks. You can shower, driving, waking up, have sexual intercourse, no problem. And you should see your doctor follow up within the 2 weeks period after surgery, because it's important to look at your wound, make sure there's no infection. Okay? I just mentioned some complication from surgery, especially in colon. Bleeding, of course, everyone is worried. Infection of the wound can happen, but with keyhole surgery, the infection rate is lower. A leak where the colon was connected back together, this is one of the main complications that the doctors worry. Because colon to colon connection, there is a small risk. It's not small if the surgery is closer to the anus, the lower part of the rectum. So for reason, because we remove some of the blood supply, so the blood supply at the rectum is very delicate. So there is a higher risk of leakage when the surgery is done closer to the rectum, a lower part of the rectum. So we will tell you, if the surgery is very low, the leak rate is higher, you may need a temporary ileostomy, the bypass of the stool, so that the wound can heal well. That is certainly happens in our routine practice. Okay? Because if you have a leak, you may develop infection in the abdomen. We have to go into the operating theater to fix it again, to clean it up, to do a colostomy. Most of the patients will be okay, but there are some patients can die from this kind of complication. All right. We have to be careful not to injure the surrounding area. Blood clot in the vein. This can happen, especially in patients with a cancer. You are at the stage where your blood can clot easier. So we routinely sometimes will give you blood thinning medicine after surgery to prevent blood clot. We ask you to move early, because when you're lying down in the operating theater, your whole body relaxes, the blood doesn't move as well. So it can form clot. And this clot in the leg, we call deep vein thrombosis, can travel to your lung and block the oxygen transfer. So you die from sudden death after surgery. That can happen. So we will do, but unfortunately we cannot see. So all we can do as a surgeon is to give you blood thinning medicine after surgery to encourage you to move. Okay? Okay, when do you call your doctors after surgery? You have persistent fever of 39 degrees and above. You have bleeding from the rectum. You have increasing abdominal swelling. You should get better and better, but now it's getting bigger and bigger after surgery. And you have pain that is not relieved by your Panadol or Tramadol medication. You have continued to vomit or chills. Chills means that sometimes you have a collection of pus inside your tummy. You have persistent cough or cannot breathe. If you have pus from any cut, and the redness surrounding the cut is getting bigger, so you are unable to eat and drink. Okay? So, having saying all this colon cancer, one thing we know, obesity and cancer. Obesity is getting worse in this country, but I look across the room today, I hardly see an obese patient today. Which is very good. But in general, in Malaysia, we are one of the fattest in the region. So obese is associated with cancer. This is proven. And one of them is colon cancer. So I want to talk about this because sometimes we can do something about obesity. Obesity is an excess proportion of the body fat where your weight is 20% more than your normal weight. The best guess is still using a body mass index. We use your height divided we use your weight divided by your height square. So when your BMI is more than 30 is considered obese. This is WHO criteria. But actually, if you do you're using a more stringent criteria like Western Pacific region of the WHO, they say 25 is obese, which I also don't agree. I think I'm approaching 25. So we use 30, okay? 25 is overweight. So what the problem with diabetes is associated with the disease that it brings with diabetes, with the obesity. You can get a stroke, your heart attack, you have arrhythmia, you have fatty liver, you have back pain, you have knee pain, you have high glucose or diabetes or your high blood pressure. Okay, these are all can be controlled just by taking care of your weight. And metabolic syndrome is a disease that now is classified because we know those who have metabolic syndrome, you have higher chance of having a heart attack, okay, 3 to 10 times more, or you have higher chance of getting a diabetes along your lifespan. So what is metabolic syndrome is you have a big tummy, you have diabetes, you have high blood pressure, you have very low good cholesterol, you have very high bad cholesterol. So this whole thing is called metabolic syndrome. So what we can do is to help you to lose weight. Actually, lose weight is very easy. You just don't eat, okay? It's calorie restriction, okay? How to lose it is calorie restriction. It doesn't matter how much you run, how much you exercise, if you eat the same food, okay? If you don't cut down your calorie, you will not lose weight. I'm not saying exercise is not good. Exercise is very good. It helps you build a healthy bone, muscle, better brain, better heart, but not your weight, okay? Because after your exercise in Taman Tun, you go to have the prawn mee, it doesn't work, okay? You have to cut down your calorie. So the surgery is reserved for those who are really, really obese, okay? Basically what we do is we make their stomach smaller. Gastric banding was very popular maybe 15 years ago, but it's getting less popular because we have problem with the tubing, patients have problem with the band, so it's getting out of favor nowadays. So the most common in the world now is sleeve gastrectomy. We basically call stomach stapling. We make your stomach like a tube, like a sleeve. So basically you cannot eat that much. You eat too much, you vomit. So it cut down your cholesterol calorie. This is gold standard gastric bypass. We make your stomach smaller on the top, and we bypass it to create a malabsorbed state so that you can lose more weight. The good thing about gastric bypass is for diabetic patients, because bringing the lower part of the intestine up to your stomach, this part of the intestine have never seen food before, so early. So it produces a lot of hormone to counteract your diabetes, your glucose state. So it does help with those diabetes patients. You will have a better glucose control even before you lose weight. Okay? So because of laparoscopic, we are able to do all this. In the past, when we see a very obese patient, we are scared because you have to cut open. And the wound will be very big. Patient cannot move few days because of pain, and they cannot breathe because of pain. So they have developed pneumonia. They cannot move too much because of the pain. So they develop blood clot in the leg. So they can die from all this blood clot. So nowadays, because of laparoscopic, we are able to do it much safer. So the number of procedures has increased over the years significantly. The benefit of obesity surgery is we can improve your diabetes 80%. We can resolve your sleep apnea almost 100%. Your blood pressure will be better. Okay, your back pain definitely will get much better, and as well as your knee pain. And those who have polycystic ovarian syndrome can get pregnant. So there are certain patients that require this kind of procedure. This is one happy patient. He sent me that every few weeks. This 1 week, 2 week, 2 week, 3 week, something. So he was 150 kilos. This is like the latest one was probably 80 something, within a year. This is the hole that we cut, the keyhole surgery. Okay, there are one big one here to remove the stomach. The other one is small one. So the pain is minimum. So how about hernia? The other thing I want to talk about hernia is part of the gastrointestinal surgery. A hernia is a defect through the abdominal wall. So there is the content they want to come out through this wall. And the most common site is your groin site for men. Okay, hinguinal hernia, we call groin hernia. The next one is umbilicus, the belly button hernia. Or some of them are incision, that means the previous surgery, who have a previous operation done, the wound doesn't heal, and then it become a hole. So all this, in the past, what we do, if we do an open surgery, we have to patch it up. And in the recent years, we have been using mesh repair. We just put a mesh there. We will see some nerve from the open surgery. But for keyhole surgery, we make a small cut in the belly button and 2 tiny cuts near the groin to do this laparoscopic groin hernia. This particular surgery is for the groin. Okay, what are the advantage? Basically, you recover much faster. Definitely, the pain is much less. Especially if for laparoscopic, you can see. For laparoscopic, you can see both sides. With the scope in, you can do both sides. For open hernia, you have to cut both sides. So we do normally cut both sides because it's quite painful. But for laparoscopic, you can do for both sides together. You have faster recovery, less pain for the first few days. Definitely, you can get out. You can go home the next day, you can drive. And you have fewer complications because the wound is smaller, less bleeding, less collection. And you have also less risk of chronic pain. In the open surgery, you will see nerve. Sometimes the nerve can be trapped during the procedure of closing. So it can cause you to have some pain even after many years after the surgery. So with the keyhole surgery, you have a less likely chance of having that happen. Of course, disadvantage, you need highly experienced surgeon to learn to do it in longer operating time. There is a report saying that recurrence is higher if your surgeon is not good. But unfortunately, you will not know how good is your surgeon unless you ask your friend. So what are the minimal invasive laparoscopic surgery offered in Subang Jaya Medical Centre? We do laparoscopic colorectal surgery. We do obesity surgery. We do gastric cancer and esophageal cancer. And we have solid organ resection as well, which is very common. The spleen, the adrenal, kidneys, we can do all that. Hernias, and laparoscopic, of course, gynecological surgery, your uterus and ovary, all can be done. All right? And in summary, laparoscopic is well established and it works in almost every part of your GI tract. It offers you a less pain and faster recovery. And colon cancer is beatable, obesity is beatable, and your hernia is fixable. Thank you very much.
Thank you, Dr. Cha. Ladies and gentlemen, we will now proceed to the Q&A session. Please give us a moment as we prepare the stage. If you have a question for our guest speakers, please raise your hand and my colleague will pass you a mic. Please state your name and where you are from. Do keep it to one question per person, please. If you have a question, please raise your hand.
Morning, I'm Madam Wong. Does having piles cause colon cancer?
No. You will never get a cancer from a hemorrhoid or piles. Don't worry. But you should have it checked out because most patients will mistake it. You blame everything on piles. Even you go and see a GP, he probably will not look at your anus. He said you have piles and give you medicine. So you should have someone check out. Okay.
Hi, morning. My name is Michael from PJ. Dr. Chen, I think you mentioned that CEA is not a reliable test. Therefore, what is the most reliable test to monitor the progress? Thank you.
So CA is mainly used in patients who already have colon cancer. So we do a baseline test for CA. So in some patients with colon cancer, the CA level is high. And once you've done the treatment, usually the CA level goes back down to normal. And we use that CA as part of the follow-up. So if it goes up again, then we worry whether there could be recurrence of the cancer. For screening purpose itself, CA not very accurate as I mentioned, because quite a number of patients who have colon cancer has a normal CA level.
Right. Okay. If after the resection, the CA persists above 6, in fact, it's gone up to 8.1. What do you think?
The screening post-surgery, post-treatment for colon cancer is not just based on just CA. So they need to do things like scans, repeat colonoscopy examination, plus the CA. So it's not just a single parameter. But if on follow-up the CA level goes up, definitely you need to have re-imaging. So normally what we would do is a repeat CT scan.
Yeah, your oncologist or your surgeon will always tell you if your CA is at the borderline after surgery and it still continue to go up, so you should do more tests, maybe more frequent tests, rather than repeating the scan in 1 year. You should do it at 6 months. Okay, because basically we need to know anything else that we miss if your CA is going up after surgery.
Yeah. Okay, so there are many other reasons why CA can go up. So if you have some form of inflammation in the abdomen, it can go up. Other cancers can also cause a high CA. So it's not just to say that it's just purely colon cancer. But again, saying that PET scan itself per se, if you have small lesions or spread, sometimes you don't see it on PET scan. So you need to follow up based on the repeat CA again. If it's still going up, you might need to repeat the imaging or PET scan to see.
My name is Wilfred from Sputi. Yeah, just want to ask, sometimes when your stool has got blood, how do you know whether it's from hemorrhoid or from cancer?
Well, first thing, the most important, probably have it checked. Because we need to do an examination. That's important. Because also during the examination, we ask you some question. The history play a very important. If your stool is just come out, if the blood come out only when you open up your bowel, you have a bowel motion, not just come not other time. So most of the time it's from the hemorrhoids. Okay, and if the stool is fresh, very fresh, and it come before defecation or after the stool come out, those are also most likely hemorrhoid related. But if the blood is mixed with the stool, okay, mixed with the stool is a little bit, you can see your stool color is changed. So those we need to do more tests, okay. And during the examination also we can see your anus and the lower part of the rectum carefully, and to see any other things. Okay, if you have obvious hemorrhoid there, so we'll tell you most of the time it's from the pus, from the hemorrhoid. Of course, we will still advise you to undergo a further test, such as the scope. You probably need first you see a doctor, and second do a scope. Well, yes, you can monitor it, but if you continue to get worse, because when you have a lot of patients come, continue bleeding for 2 months, 3 months, and they come with very weak, very pale because of blood loss. Patient looks pale and weak, short of breath because of blood loss. So there are things like that. So you have to be monitored. You should have the doctors check it out if the bleeding intermittently for some times, okay? But having said that, fresh blood during defecation is most of the time hemorrhoids, okay?
I think if you're above a certain age group, if you're, let's say, above 40, and you start having fresh rectal bleeding, I think probably advisable to check, because sometimes you can't be sure. Yeah, although we can tell that most likely it's hemorrhoids, but you do have patients who have low rectal cancers presenting exactly like hemorrhoids bleeding.
Sorry. This gentleman.
Dr.
yes.
Cheng, from the colposcopy, when you found the polyp, what is the characteristic of a polyp? Only you know determine that the polyp is cancerous or not, based on size or?
So there are quite a few criteria to see whether the polyp is cancerous, but in the end, it's the pathology. So once we remove the polyp, we send it to the lab to examine. The histopathologist will look into the microscope and see whether there is cancer or not. But certain features such as the appearance of the polyp, how easy it is to bleed, if it's a large polyp, then we know that these are, or it looks irregular, then we know that these are most likely cancer. Even endoscopically, we can tell most of the time whether the polyp is a cancer or not.
That gentleman over there.
So by and large, most patients when we do scopes won't have too many polyps, maybe 3, 5. So we will take everything out. There are some patients who have many polyps. Some of those with genetic condition where they can even have hundreds of polyps. So those patients, we take out the biggest, the ones that look the most suspicious. Usually we stop either because of time. Sometimes you can't take all out. The more you take, the higher the risk of complication as well. So we take out the highest risk ones, and then we get the patient to come back maybe a few months after to repeat the procedure. But most patients don't have that many polyps, so we will take everything out during one sitting.
Gentleman in
Yes.
white.
Morning, Dr. Chen. I'm Low here. Now, he has about referring to polyp again. Now, you say that most colorectal cancer derive from polyp, but not all polyp are cancerous. Now my question is, can colorectal cancer derive from non-polyp, meaning just from the wall of the colon? And also, if the polyp is non-cancerous, if you don't do anything, what happens in the end to the polyp? Will it just go away, or will it become bigger, or yeah?
Okay, so your first question on does all colon cancer come from polyps? Not all. Majority, I would say almost all of it. There are, as I mentioned, patients who have conditions called inflammatory bowel disease, where they have long-term inflammation of the intestine. So those patients, they can get changes in the lining itself, and they don't present normally with like a typical polyp, and that is what becomes cancer. But again, those are very uncommon. Not all polyps will become cancer. There are polyps that we call hyperplastic, which has very low risk if it's small. But by and large, most of the polyps would be what I mentioned, the adenomas or the serrated. So most of it, if you leave it long enough, it will be a cancer. So normally, that's why when we do procedures, if we see it, we will remove it.
Gentleman at the back.
Yeah, I'm James O. I'm a cancer survivor. So I also like to ask if people like me who have stomach cancer and my medical record is shown that there is no evidence of cancer cell in my body. So my question is that what is the chances of getting this what I call colon cancer in the maybe next 3 years or next 3 to 5 years time? And what is the chances of getting this? If yes, the answer is yes, then what is the chances like? And then can I raise another 2 questions?
Yes, yeah. Just one by one though. Yeah.
Okay, so stomach cancer by and large is not related to colon cancer. So most of the stomach cancers in Malaysia would be caused from the bacteria called H. pylori. That's the most common cause. Of course, you have some genetic condition where patients can get colon cancer with stomach cancer, but those are extremely rare. So if if the stomach cancer has been treated, you've been well, no recurrence, your risk of having colon cancer would be the same as the average patient. So same thing, screening at a certain age as well, that you don't have to do it earlier compared to other patients.
Any other questions before I go back to? Okay, I'll come back to you. Lady over there.
And then by the time you screen within 10 years, you may already have cancer. So is it advisable to combine the colonoscopy with the fecal occult test in between? Another question is, while you say it's minimally not dangerous to do it, so as you grow older, let's say a person lives to the ripe old age of 100, do they keep continuing to do colonoscopy every 10 years?
Okay, very good question. So colonoscopy is not 100% protective. Yeah, we know that polyps can be missed, but by and large, if the bowel preparation is very clean, most of the time we can be pretty sure that there's no polyps. And if you do the scope itself, the worldwide recommendation for countries doing screening is 10 years. Why? It's also partially because of cost issue, because colonoscopy is expensive. If the bowel prep is clean, there's no polyps, I tell my patients 5 to 10 years is actually fine, because the risk of having cancer will be very, very low. Yeah. Do you supplement it with a stool or cord blood, the FIT test? You can if you want to. That might increase your chances of picking up a lesion earlier or a missed lesion. You can do it, but by and large, we just do, if we do colonoscopy, we follow the schedule. Yeah. Sorry, what's your second question again?
I don't think you should. Average Malaysian women probably live until 79, 78. Yeah. So if you are over 80, I don't think you should go through another screening colonoscopy. You should open a champagne and celebrate.
Most of the countries actually recommend stopping by the age of 75, because if your scope is okay, you know, the next 10 years you won't have any problems. You won't have any trouble from colon cancer troubling you. So, yeah.
Hello, good day, doctor. Is tubercular disease likely to lead to colon cancer? What are symptoms of colon cancer? Is persistent fatigue is one of the causal factors? Persistent fatigue can lead to, it's likely causal cause of the colon cancer.
The first question is diverticular disease, right?
Can it lead to
no, diverticular disease will not become cancer. It will not develop and become cancer because there's no abnormality in the mucosa. What it does is just basically a weakness in a colon wall, and there's outpouching of this colon wall, but there's no abnormality. It's not like inflammatory bowel disease like ulcerative colitis or Crohn's disease. So you are safe with diverticular disease. In terms of fatigue from
persistent fatigue, yes.
No, fatigue is basically you have to have checked out by your blood test first to make sure you are not anemic. That means your hemoglobin is fine, and why you are having this problem with fatigue.
Yeah.
It's not related.
I heard eating satay is not good for colon. I don't know. I heard I don't know. I heard that when you eat satay all the while.
Oh, I see.
I think it's not very good for colon or not. I don't know. I heard only.
In general, satay is meat. Okay, meat is good because there's protein. There's no. However, anything too much is not good. Satay don't cause cancer.
Yeah. Can I have a ballpark figure roughly about how much a colonoscopy costs? And the other thing is colonoscopy examination. Does you do the whole entire length of column or just a left side?
So I think the cost of colonoscopy would depend on which different centers will have different pricing, but I think by and large normal colonoscopy would range probably about 2,000 to 3,000, I think, roughly. But it depends on whether there's polyps there. Because if you have polyps, you have multiple polyps, we might have to use different devices to remove the polyps. You might have to use a clip if there's any bleeding. So with all these additional things, the cost may go up, but usually it's about roughly there, yeah, 4,000 plus. I think most centers.
My question to you is, understood that polyp would develop into colon. What about in other organs, for example, gallbladder? Will it be, gallbladder?
Luckily, gallbladder polyps, most of the time is cholesterol based. It doesn't become cancer. It seldom develops into cancer. However, the standard recommendation from us is if your polyps in the gallbladder is large, maybe more than 1 centimeter, or there are multiples, so we will advise you to have it removed. Okay, because sometimes these polyps could be just a stones that is misinterpreted by the ultrasound. It's a cholesterol stones. So, and normally we will recommend if it's polyp is too large or multiples. If it's just one tiny one, we'll ask you just to do a routine follow-up ultrasound check. Should be fine.
Morning, doctor, for the nice presentation. My name is Raymond here. I understand that the UC patient has a higher chance of developing cancer, right? UC, ulcerative colitis patient. For patient with, say, 10 years history and maybe 25 cm, when would you recommend surgery? Or if surgery is necessary? And the other question is, roughly what will be the cost like for surgery?
So I think the first question is, so ulcerative colitis is a complex disease where you have inflammation along the whole of the colon. It can happen in certain parts or the whole colon. So for patients with ulcerative colitis, the risk for colon cancer goes up when you have a longer disease, more than 10 years. And also the extent of the inflammation. So if you have like 15 cm, 20 cm inflammation, generally your risk doesn't really go up. So it's more for those who have moderate to extensive inflammation involving almost the whole of the colon. You don't need surgery most of the time unless you have complication from the ulcerative colitis. Or if you have extensive inflammation, and when we do screening for patients and you find that there is areas of what we call dysplasia within the lining, then these are the patients that will need surgery. Yeah? Other than that, normally you don't need to. And most of the time, ulcerative colitis is controllable and treatable by medication.
I agree. I don't think you need surgery for ulcerative colitis unless it's complication related, like bleeding, a lot of perforation or pus. In general, you don't need surgery for ulcerative colitis. For laparoscopic colon resection, we are talking about in the ballpark about 40,000-50,000. Okay, even just like open surgery nowadays, whatever we use for open surgery, the only additional things to use for laparoscopic surgery is just the trocar that I show you, the few cannulas, a video camera, and certain stapler devices. So pretty much that are the added costs. The surgeon charges you the same fees for open or laparoscopic procedure because government control, and pretty much just the additional apparatus, the instruments that we use. So the ballpark is 40,000-50,000 for the left-sided surgery. But for the right-sided surgery, which involves the right colon, which is much cheaper, that one will cost you about maybe 20,000 to 30,000 can be done.
Lady at the front.
Does frequent constipation cause colon cancer? I came across some friends, they only remove bowels 4-5 days once.
So the bowel opening, the duration actually varies from patient to patient. So some people, they may have had this kind of bowel habit since they are young. It doesn't put you at an increased risk for colon cancer. Constipation, if it's a new sign, for example, if you've been passing motion regularly and suddenly over the past 1 month you have changes, then yes, this is one of the things that you should have it checked out. But again, constipation as a sign of colon cancer is not a high risk, not as high risk as compared to the others. No, because it depends on the person's bowel habit, because the colon movement for every person is different. So that may be normal for quite a number of people, and it doesn't increase the risk for colon cancer for those patients.
Gentleman to my left.
Doc, I have a question. Is constant bloating after meals, chronic constipation, and difficulty in passing wind any indication of cancer?
Okay, so bloating again, very common symptom. Not really a alarm symptom, but there can be other things that can cause that. Can be from gallstones. You can get bloating. You can have some gastric inflammation. There can be a bit of delay in the movement of your stomach or your colon. So it's a very common symptom, but it doesn't mean that you have a higher risk of having cancer. But again, if all these symptoms are very recent, it's a big change from your normal symptoms, you should have it checked out. Can be other things as well.
Any more questions? Otherwise, I'll return to the gentleman. Yeah.
I'd like to ask about the H. pylori, because normally it's treated with antibiotics, but let's say you miss the test and the pylori is in your stomach. How long does it develop into stomach cancer? And also, do you do the pylori test when you do the colonoscope?
So the H. pylori is a bacteria which causes problem in the stomach. It's actually quite a common bacterial infection. So if you look at the studies in Klang Valley, I think about 10-15 years ago, they tested population to see how many percent has it. I think about 10-15% of people actually have H. pylori. Not everybody who have H. pylori would end up with problems from it, but we know that most of the stomach inflammation, stomach ulcers, stomach cancer is caused by this H. pylori. So it's something that people get when they're young, not so common when they are older. So if you have it, it means that you probably had it for quite a few years. Normally, if we find patients having H. pylori, either by blood test if you've not been treated before, or the breath test, or when we do scope for the stomach and we take biopsies, normally we would just give antibiotics to get rid of it. Yeah, but saying that, for those patients who have taken antibiotics, you need to make sure you do a breath test after to make sure that the bacteria is gone, because antibiotics clearance rate is probably about 80-90%, so you might need a different line of antibiotics to get rid of it.
Gentleman at the back first, just one.
Eating too much chili, hot chili, cause colon cancer?
No. No. Correct. Like Dr. Chen said, if you like it, it's good. It's whatever too much is no good. Right? Moderation is the main thing. Yeah. But chili doesn't cause colon cancer. In fact, chili component in the chili doesn't cause gastric ulcer. No, it doesn't cause. What happens is when you eat too much chili, sometimes it causes gastric reflux. You loosen your lower sphincter of the esophagus, your food pipe, so acid come back up easier. So if you feel very bloated, you feel discomfort, indigestion. Actually, most of the time, chili cause reflux rather than gastric pain, gastric ulcer. So there's good things.
Gentleman at the back, please.
Yeah, Dr. Chen, just now you were showed the chart that the Chinese have higher chances to get this colon cancer lah. And perhaps you can share with us what are the research findings why this group is have higher chances of having cancer, and then what are the precautions we should take as a Chinese community?
I think colon cancer is quite a mixed causes. So there's environmental, there is genetic risk factors. So I think we are not very sure why the Chinese population have a higher risk. Maybe genetic, but maybe also partly because of the food and all that they take, preserved food. So it's multifactorial. Yeah, but this is just observational study. Why we find them more in Chinese.
Sorry, lady at the back first.
Hello. eating probiotic food like kefir actually helps to give you a healthier colon, thus preventing cancer?
Probiotics. There's no study to show probiotic actually prevent cancer. Okay. At the end of the day, from the nutritional standpoint, the things that can cause the increased risk of cancer, not cause cancer, but increased risk of cancer, is those processed meat. Okay, processed meat, and mainly, yeah, pretty much so far at this stage. But there is no study to show probiotic actually prevent colon cancer. It does probably regulate biodata in your gut, it improve your bowel motion maybe. So, but it doesn't really, prevent anything.
Yeah, doctor. What is the cause for the formation of polyps?
Well, sometimes we don't really know. If one thing is hereditary, that means the family history, some of them. Some inflammation in the colon can increase risk of polyps formations. That's why there are studies to show anti-inflammatory drugs may reduce the polyps formations. Okay, but how much to take, we don't know.
So it's actually quite common. So I think if you look at the studies on patients who are 50 and above, I think probably about 10% may already have polyps at that age. So it's not to say that there is one single cause for why you should have polyps. It is multifactorial, as I mentioned, but it's quite common.
Sorry.
I disagree with that statement. I'm not an expert in nutritional science. What is important is try to not take all these processed meats and processed food, whatever chemical that is introduced in a food processing procedure. Therefore, what we can do as a patient or as a human is basically try to eat whole food, all right? Natural, whole food. Anything in package, look twice before you eat it. So that is my advice, okay? But Japanese actually quite healthy. They don't eat processed meat that much. They eat healthy fish, beef. So those are what we know.
Ladies and gentlemen, if you have a question, please raise your hand and my colleague will pass you a mic. This is just to ensure that everyone can hear you. Okay, thank you. Lady at the back.
Doctors, earlier you said people with family history, if they are young men in their 20s and on the paternal side they have an uncle and an aunt who have died of colon cancer, do they need to screen in their 20s? And do they need to go in every 10 years for a screening?
We know that first degree relative, for example, mother, father, brother, sister, carries a high risk, but even second degree relative also would increase the risk of a patient having colon cancer. The screening again depends on the age. So if you have, let's say, more than one second degree relative with a young colon cancer, young as in below 50, yes, I think you should screen them early. So 10 years before the occurrence of the youngest colon cancer. So I think if you have a strong family history, for example, if you have a first degree relative colon cancer at 30s, it's 10 years before. So 20 something you should start.
Any more questions?
Yeah, this question is for Dr. Chen. Recently I've read about this RNA screening, which is a non-invasive screening from Canada. Apparently it is a diagnostic tool for early detection of cancer. I wonder whether we have such a screening available in this country.
So the DNA testing is by stool or is it blood? So we have the Septin-9, as I mentioned earlier. Septin-9 is a blood test for colon cancer. That's the only one that's FDA approved so far. There are a lot of other research now for all these blood tests to try and pick up colon cancer, but the sensitivity is not very good. It's only about 50%. We don't have it in Malaysia.
To the right.
Just a question about intestines. Colonoscope, I think they check the colon, which is the big intestine. How about the small intestine? Do they check it during the endoscope? Or can polyps form in the small intestine as well?
So usually we do our colonoscopy, we try and enter into the end of the small intestine, which is the ileum. But by and large, small bowel screening is not recommended because the risk of cancer within the intestine, small intestine, is actually very rare. So I think it's probably about less than 1%, 2% of all GI cancers. So by and large, if there's no symptoms, you actually don't do screening for small intestine cancer. So if you do from the stomach, the small intestine is a very, very long organ. So if you, let's say if you do a upper scope, going to the stomach, we go to the first part of the small intestine called the duodenum. If you do the colonoscopy, you go to the end of the small intestine as it joins to the large bowel, the ileum, but you won't see a big part of the middle part, so of the small intestine, unless if patients have things like bleeding that we're not very sure where from, or if they have a possible growth in the small bowel, we have all the other modalities to assess the small bowel. We can do the capsule test, we can do a special scope which goes into the small intestine, but we only do it when there's an indication, not as a screening.
Right. Gentleman in brown here.
So, doctor, it's like this. I went for a medical checkup and everything is fine and good. So then my doctor asked me, do you have any question? I said, yes. Do I need to go for a colonoscopy screening? Then he asked me, do you have any symptoms? I said, no. Then he said, that is okay, no need to go. Then how come you all said that your screening should start at after 50 or earlier 40 or so?
Like I said, I advise my patients if you can afford it, and if there is someone able to provide you the service, and you should do it earlier, maybe 40, 45, okay? The general recommendation is more than 50, okay? So the reason we do screening is because most of the tumor is asymptomatic. There's no symptoms. So we don't know. When you have symptoms, it's too late. And we have to emphasize again, when you have symptoms, even like bloating, difficult in changing bowel difficulty in passing bowel motion, or have diarrhea, constipation, interchangeable. So those are symptoms. It's sometimes quite late. So you should do it. If you are healthy and you're above 45, 50, then you should have it done.
I mean, I think the understanding of colon cancer and all that is progressing quite rapidly. So sometimes they may not be up to date on what is the current recommendation and all that. But like Dr. Chia said, when you have symptoms, usually the cancer is very advanced. So most colon cancer that we pick up for symptomatic patients would be at least a stage 3, so cancer. We don't want that. We want to pick it up when it's still a polyp, you remove it, basically you're preventing the cancer from occurring. So that's why the screening topic has come up and why it's so important. And that's why a lot of developed countries actually have this screening program, because we know that colon cancer is preventable.
Malaysian government did not offer screening program because we have not enough money to spend on this screening program, and also not enough manpower in the government hospitals. Therefore, the health ministry never talk about it.
Gentleman at the back.
Yeah, Dr. Chen, just now you showed us that the population of the cancer population is already increased. So may I know whether it's a single digit or double digit growth? So maybe for the last 5 years.
Sorry, what do you mean by... Can you repeat your question again? Sorry.
Oh, Yes, one of the charts that you showed us is that the what I call the population of the cancer population is growing, right?
Yes.
So my question is whether is it single digit or double digit growth? That means for the last 10 years, maybe 5 years, is it maybe 5% or 10% or maybe higher than that?
So it's increasing quite a bit. So if you talk about colon cancer, those below 50 is quadrupled 4 times. Although the absolute figure is not really large because majority of colon cancers are above 50, but those younger actually has increased quite significantly. So I wouldn't know the ballpark figure of percentage, but it's quite significant. Yeah.
Oh, I see. Okay. So I guess it's for
Dr. Chen, I'm Bing Hin, I'm from DDTI. Again, the questions on polyps. Actually, during colonoscopy, if polyps are discovered, at that stage, who actually determine for the removal or don't need to do at all? And the next question is, after the removal of the polyps, will it recurring again?
Okay, so usually before the procedure, we would explain to all patients that when you do colonoscopy, if we find polyps, almost always we will remove it. So the only time we don't remove it is if the polyp looks very tiny, looks like a hyperplastic polyp at the rectum. Sometimes we don't take out all of it, or if it's a cancer. So if it looks like it's a polyp that's already changed to a cancer, then we don't remove it because the risk of complication is there, and you don't clear the cancer by removing it because it may have spread to the nodes. Those patients are the ones that need surgery. But if we do find polyps, usually we will remove it because by and large, as I mentioned, the type of polyps that you get most of the time is the adenomatous. That's the one that causes colon cancer. We can roughly see when we do the scope the type of polyps that is occurring, and we usually will know whether it's those that can cause, and we will remove it.
There was one more. Sorry.
Yes, polyps can recur. So that's why the screening schedule is there. So if no polyps, 5 to 10 years basically, you don't need to repeat again. If there's polyps, then you would do it earlier. Not to see whether the small polyps that you remove, whether it comes back, but it's at different sites of the colon.
There was one more here.
This question is for Dr. Chen. Yeah. Just now you mentioned about this capsule endoscopy. How come it's not commonly used, this capsule endoscopy? Because it's quite simple, just swallow the capsule pill. Just you take everything from the top right through the rectum.
So we have different type of capsule device. Most of the time, the capsule endoscopy that we use is mainly for small intestine. It is meant for that, to look at the small intestine for patients who we think have some small bowel disorder. The capsule colonoscopy is something quite new as well. But the problem with capsule colonoscopy is that it's expensive. It's almost as expensive or maybe even more than a colonoscopy. And you still need to go for the bowel prep. You have to drink the water to purge. And if you see polyps there, you will still have to go for colonoscopy to remove it. So there's a lot of drawback, but some patients, they think that they want to avoid the procedure, they might want to do that. So that is also an option. Or the CT scan, as I mentioned before in my presentation. But in the end, if you find something there, you will still have to go for the colonoscopy to remove the polyps.
I think we can take.
Yes, we do capsule endoscopy, but it's more for the small bowel. We do CT scan, CT colonography, we do colonoscopy examination in SGMC.
I think we can take 1 or 2 more questions. Any more? No? Okay. Oh, last one. Yeah.
Dr. Chen, just now you mentioned the CEA marker is not reliable. Then actually almost all this screening package includes CEA, and I think Subang Jaya Medical package as well. Isn't that misleading?
No, I don't think our Subang Jaya in the general screening profile is not included. I always have to tick extra if I want to order it. If you have to category, we have to say no. In the general screening profile in HMC, there's no tumor marker. As a doctors, we have to add on it, okay? But we do see a lot of this done from the outside, the labs, the Gribble labs and all these things. And routinely, we can see them all the time. They come in and see me, doctor, it's like showing me like 6 or 5 point something. It's a bit high. What should I do? So then, therefore, it brings business to the hospital.
If that's all, thank you, Dr. Cha and Dr. Chen, for taking our audience's questions. You may return to your seats. Okay, ladies and gentlemen, the body composition assessment is still going on there. If you haven't done it, please head to the health test room. And with that, we have come to the end of today's StarLIVE session. Big round of applause to Dr. Cha and Dr. Chen, please.